Hello, everyone. I'm really happy to have Dr. Sarah Hampl. She is a board certified in pediatrics and obesity medicine and is a professor of pediatrics at the University of Missouri, Kansas City School of Medicine. She's a member of the Division of General Academic Pediatrics at Children's Mercy, Kansas City, and directs advocacy initiatives at the Center for Children's Healthy Lifestyles and Nutrition. She has been working with children and families with obesity for the past 25 years. She provides clinical care and promoting health in teen and kids weight management clinic and is the medical director of weight management group programs. She's a member of the AAP section on obesity and a coach for pediatricians in the Midwest who are working with children with obesity. She leads a Project ECHO for pediatric obesity. Dr. Hampl was the chair of the writing committee for the American Academy of Pediatrics Clinical Practice Guideline on Childhood Obesity. And from this point on, we're going to refer to the clinical practice guidelines as CPG for short, so I don't have to say it so many times. So the objectives for this session are, by the end of the session, participants will be able to describe the main components of a thorough evaluation of a child with obesity. They'll understand patient-centered methods of communicating about obesity with patients and families, and they will be able to discuss different treatment options for children with obesity. Thank you for being here, Dr. Sarah, or Dr. Hampl, I'm sorry. We're really happy that you're here.
Miranda, thanks a lot for the invitation. I've really enjoyed getting to know you a little bit, and I'm happy to be here.
Thank you. So let's start by discussing, it's been 15 years since the American Academy of Pediatrics has came up with anything about guidelines for childhood obesity. So why did they decide to create new guidelines for childhood obesity?
Well, because it has been a very long time, and the amount of evidence has really just skyrocketed since the 2007 recommendations were released. And, I really still like those recommendations a lot. And they were, they were very good. But in the intervening years, there's been so much more research that's happened. And also, rates of obesity have continued to increase in kids. And so this was a great opportunity that the American Academy of Pediatrics had to form an actual formal clinical practice guideline for obesity, and I was thankful to be a part of it.
Yeah, I'm glad you were able to be a part of it. It's really exciting. I've been taking my master's in public health, and I have been referencing the practice guidelines so much in my discussions and papers because they're all about childhood obesity. So let's talk about, can you tell us what are the main components of the guidelines?
Sure. And I want to just mention that it was a really thorough evidence review process that actually started back in 2017 with
Wow.
an evidence review committee. And they got started doing a review, and they ended up reviewing like over 16,000 abstracts of scientific articles, and they narrowed it down to 1,600 full text articles, and that was around 380 studies. And that evidence review committee really set us up well as the writing committee, because they, again, applied a really rigorous evidence review process to look at all the different studies and created a couple of different technical reports. One of them is on interventions or treatments for obesity, and the other one is on comorbidities or complications of obesity. And we used those that technical report for each of those to write the clinical practice guideline. And so the guideline, at the same time, we were also incorporating newer evidence that was coming out as we were writing it. So a lot of different things to keep track of, but the ultimate clinical practice guideline consists of 13 key action statements and 11 consensus recommendations. And in general, it is a pretty comprehensive look at children with obesity, all the way from risk factors and how to assess a child, all the way from body mass index to different things, factors that need to be included in the physical exam and the history of a child. And it then goes into the complications and how to assess for the complications of obesity and how to follow a child with those complications, like when should you recheck lab, for instance, and how should you do some initial management, or what are some initial management recommendations for those complications. And then it launches into the different, an overall treatment approach, and then what are some of the tools in the toolbox for pediatricians to use in managing children with obesity in the context of the family, and then finishes up with what are some barriers and facilitators of actually implementing the CPG, what were some of the evidence gaps that the evidence review committee found, and then what are some policy recommendations for moving the CPG forward, because we definitely don't want it to be a static thing. We want pediatricians to be able to use the different resources that have been developed to help implement it and make it real in their offices. So that's
And I
kind of
love
a
that
broad
because,
overview.
I think that's something that a lot of pediatricians struggle with is knowing how to manage obesity. And I think, sometimes they feel overwhelmed. And so then, it isn't always addressed. So I think it's great that the American Academy of Pediatrics is trying to make that simpler for pediatricians so that so anybody can do it. I really think that's important.
Thank you, Marina. And I'll just mention a little bit about some of the new recommendations, or what's new from the 2007 expert committee recommendations. So I mentioned the research piece is that significant, but also, along with that, there's more knowledge of the implications of obesity as a chronic disease, that it's not something that most kids are growing out of these days, and how we need to look at it over time and longitudinally, and how to help the family understand that. We also understand more about the social determinants and other social risk factors that impact a child's risk for obesity, and that some of them have like physiologic impacts on the child. We also know more about weight bias and weight stigma, and how that can be a barrier to treatment, and how healthcare professionals also can have weight bias, and what we can do to help combat that. We also know, versus the 2007 recommendations, that we're a little bit more staged in the approach, maybe waiting 6 months or so before going on to the next approach, that there really is evidence now to suggest that treatment should be offered early and immediately, that there's that there are, again, a number of tools in the toolbox. And yes, we should have kind of what is foundational treatment, but there are other treatments that can be considered earlier rather than later. That when you do treat obesity, you're actually treating the complications of obesity, because so many of the comorbidities will improve with improved weight, or even stabilized weight as kids get taller, or even some of the healthy behaviors, even without weight change, can lead to improved other health indicators, improved lab, for instance, and that structured, supervised weight management treatment actually decreases current and future eating disorder symptoms. So that's evidence has built for that approach. So it's definitely something that we want pediatricians to help kids think about
But can I
earlier.
stop you just for a second,
Yes.
actually? So talking about the eating disorders, we actually so our January Project Echo was actually a psychologist who was talking about the prevention of eating disorders with obesity and how to have conversations. So I think this goes along great with that. But yeah, so I just want to reiterate that fact that you talked about. So structured weight management actually helps prevent those eating disorders. So, sometimes I think when we talk about it, when we address it with our patients, we're going to lead them to that. But
Right,
actually,
right.
when we do it correctly, it actually helps to prevent it.
Absolutely. And that, kids continue to be monitored. So, when they do try to do it on their own, or or try a fad diet or any number of things, as you probably learned about last month, then they can get into trouble, because we know that kids with obesity do have higher risk for disordered eating. So we want to be assessing for that, and also reassessing as treatment ensues, and seeing kids back frequently, and supporting them. So yeah, so those are a few of the kind of the key differences, the complex chronic disease nature of obesity, and then a number of different, other newer lessons that we know about now that were not available back in 2007 when the expert committee recommendations were created.
That's exciting. When I think too, I wanted to focus on, so talking about public health, so the importance that you guys used evidence-based things, that you were looking at evidence-based research. And that's really important because that's what's proven to be successful and work. So I think it's wonderful that, we know these guidelines were not just developed on a whim. It was actually,
Right.
it was evidence-based, and it was, as you said, a very thorough process that you really, a lot of thought went into this to make sure that it was accurate, and we really want to be able to help these patients. That was the goal of it,
Absolutely.
is
And
to really,
that evidence review process, it went on for a couple of years before our writing committee actually even got started. We got started with starting to, think about what did we want the CPG to look like back in 2019. And then we had our first face-to-face meeting in early, like February 2020. And then the pandemic hit, and it was really inspiring to see how people just persevered through that to continue to write the CPG, because we had just barely kind of gotten started with our writing groups, and then the pandemic hit. So that led to, we would have liked to have gotten it out earlier, but we just could not, and
yeah,
do the
can
job that we
imagine.
wanted to do. So
Yeah, I bet
uh,
that was difficult.
it was, but I really appreciate the writing committee. We had just a great, diverse group of clinicians, researchers, epidemiologists, policy and implementation experts, and a parent who did a fabulous job. And, they all worked together so well and persevered, through a lot of back and forth. So, my deepest thanks for both myself and Sandy Hassick, who was my vice chair, go out to that committee, because they just worked so hard over many years. And I think it just shows, we love taking care of these kids and their families, and we want the very best care for them as possible. So I think it really points back to their dedication to that as well.
Yeah, that's great. Yes, actually, and know Dr. Hassink as well. And yeah, she's a wonderful person, and she loves seeing her patients and gets so much
Yes,
joy out of that. She was listening to a podcast this weekend, and she was talking about that, how much she just can't wait to see her patients. And I think that's a wonderful thing, because they need our help. And I think it's wonderful that, we really want to help them. And so I'm appreciative to both of
absolutely.
you for that. So any other components, or can we go on to talking about the approach?
Yeah, let's go on and talk about the
Okay.
approach. I
Yeah,
think
so something that, oh, go ahead. I was just gonna say, so pediatricians, I think in general, they've discussed a lot with us about they're not sure how to approach a patient with obesity. And I think that's one of the most overwhelming things about when we have a patient with obesity. So I think it's really great that we're gonna talk about this today, but if you can kind of tell us how we can approach it and what's the best way.
Yeah, so I want to say to the pediatricians that are listening, you all have a lot of strengths, and just like families have a lot of strengths as well. So a strengths-based approach is a really good way to think about this issue, and a whole child approach. So our general approach in writing the CPG, and I think that this extends to the evaluation of the patient as well, is to look at the whole child. So we're looking at, what are the risk factors, and how those could be definitely not just genetic and biologic risk factors, but also environmental risk factors, social risk factors as well, that affect the child's weight and their ability to carry through with some of the treatments that may be offered. So, in thinking about though, how to approach it, first of all, pediatricians should lean on their strengths. They have good family um, engagement skills. Pediatricians follow kids their whole, many times their whole childhood and into their young adulthood. And we have rapport, we build rapport. And um, there are a number of different resources that can help pediatricians, again, build on their inherent strengths to have a conversation and have multiple conversations. And the general approach that we recommend and that is supported by the literature too is called motivational interviewing, which really puts the patient and family in the driver's seat and recognizes them as the experts in their own family. They know themselves the best, and parents are their kids' first role model. So parents have a tremendously important role to play, and really knowing the child. Knowing, is this something that I can talk about with the child in the room, and the way that I talk about it might not use the term obesity. It might talk about, can we review some of the concerns that you guys have about your child's health today, and see if weight comes up in that. And then the pediatrician then has the chance to say, would it be okay if I shared some of my observations or some of my concerns when I look at how your child is doing. And sometimes that conversation, again, especially with a teen and a parent, may be able to happen in the room, and a younger child maybe also. But it kind of depends, again, on that relationship that you've built. So really, the overall approach is, again, empowering the family, building on their strengths, seeing how they have been successful in other areas of their child's life and health, and how can we build on those inherent strengths of the family, to to talk about this, to see, is there concern in the family or not? Are they worried about their child's weight? Is the child themselves worried about their weight? Is it how is it affecting the child? Is it stopping them from doing anything that they want to do, or is it something that really isn't on their mind? And that can also give you an idea of how ready the family may be to continue the conversation. And I think one of the biggest things I try to encourage my colleagues in general pediatrics to do is, don't think you have to do this all in the context of the well child visit, because there's so much that has to be covered in the well child visit. And you want to make sure, especially, that you are giving enough time for you and the family to really talk about this a little more. So even, if there is some interest and some concern raised at the well child visit, could they come back, in a month or in a few weeks, and just have a visit that's focused on, let's talk about your child's weight and their health, their overall health. So there are a number of tools that are helpful for pediatricians that are on the AAP, Institute for Healthy Childhood Weight website. One of them is a great module, just an interactive module called Change Talk. You may have seen it before, Miranda. It's a really fun avatar-based one. It takes about like 30 minutes to do.
Yeah, you can actually download. You can get it on your phone too. So I've done it on my phone. Yeah.
Yep. So that's one of the tools. There are a number of other ones as well, but that's a nice introduction to, okay, this is how, I can explore with the family. Do they have any concerns, and what is their concern? Because you may have 5 concerns in your mind as the pediatrician, but a good way to approach it is, what is their concern, and maybe exploring that a little bit first, and then over time you can maybe get into what some of the other concerns are. The other thing I think that's nice about this motivational interviewing approach is that, again, recognizing that families know what will work and what is too much for them. So in other words, you might have 10 different things that you really see as an issue after you're assessing their, their eating history, their physical activity and sedentary time history. And, you may have a number of different things that you think might help the child achieve a healthier weight, but it's really best to try to go with what the family wants to work on first, and 2 or 3 things, or maybe even 1 or 2 things, and not 10 things, because that's overwhelming and can lead to a feeling of failure if the family doesn't achieve that. And for any of us, eating healthy is a challenge. Getting enough physical activity is a challenge. And, again, the attitude, the approach with motivational interviewing is really letting them talk through some of what they feel like are the barriers for them, and then working with them to develop what might be a feasible goal to set. So that's just kind of an overview of the approach. But then the CPG really talks about a number of different things to look at with the child. So yes, BMI as an indicator of potentially that there may be some excess adiposity. It's not a perfect measure, but it is kind of the best wide population health based measure that we have for indicating that maybe there is a concern about excess weight. And then going into the risk assessment, again, not just the eating history, the physical activity and sedentary time history, but what is the family's access like to healthy food? What are some of the family's views about body weight and acceptability of certain body sizes? What are their barriers for physical activity? Do they live in a safe neighborhood where their kids can get outside? And a number of those things. So it covers the whole risk assessment of the child, and then the evaluation, including the physical exam, the review of systems, screening for disordered eating, again, because we know that kids with obesity have higher rates. And then looking at what lab indicators should be done, in addition to blood pressure, which should be done, what lab measures should be done, and, and how often should they be repeated. So I think kind of the big message with evaluation is assess and reassess and reassess, because we know that even if comorbidities are not present at the beginning of your work with a child, they might emerge as time goes on. So assessing and reassessing, and again, assessing in the context of the whole child and that kind of that socio-ecological model, more about the family that they're within and the community that they live within, and so forth. So
That's so
that's
important. I think, like, I love that you address the social determinants of health, because that's such a newer thing, but it's so important. Like, we really have to assess that. And I think sometimes we forget that, just we used to think, oh, they're not, it's all about what the parents are doing or what the child is doing.
right,
But
right.
we know now the environment really does influence. And if they don't have
Absolutely.
access, then, there isn't an opportunity for them. So I think we
Yeah.
really do have to make sure as pediatricians, as providers, that we are asking those questions and finding
And
out those
hopefully,
answers.
being able to connect them with community resources. So we mentioned a little bit in the CPG about what are some of the quicker measures that you can do for social determinants, and then, again, connecting them with resources, whether it be for food insecurity or housing or transportation or a number of different things. So it's great to assess. It's even better to have, a referral, that the family, a community resource that they can look to. And again, these are more and more recognized as important aspects of people's health.
Mhm.
So I think that in the future, we're going to see more and more of those, web-based resources, like, type in your zip code and it'll tell you what is available in your area for a food pantry or so forth. The other thing, Miranda, that I didn't mention, but that is very important, is how's the child's weight affecting them emotionally? So
Mhm.
looking at, quick, again, indicators for anxiety or depression, or concerns about self-esteem or disordered eating. A number of different things should be looked at. And that's why, again, it's very hard to get this all in a well child visit to really,
Yeah.
have them come back and be able to do more of a thorough assessment. So that's kind of in a nutshell what we included in the comorbidities to screen for. There are a number of them. We didn't include every single one that might affect a child, but we did
Mm.
include the main ones, and then we have some so the main ones being high blood pressure, glucose metabolism issues, whether it be prediabetes or diabetes, fatty liver disease, lipid disorders, and then, looking at some of the other ones that are also present sometimes: obstructive sleep apnea, depression, PCOS, a number of orthopedic complications. So we've got quite a bit in there, and then we have some additional material in an appendix as well to help get for pediatricians to know at least some initial management.
Great. So I have a question talking about approach. So what do you do with a patient that is not concerned? So they're not concerned about their health. They don't think that their weight's a problem. So what is your approach with that? If you want to share that, because I know that's something we run into a lot. The parents think that they're fine and they don't think that it's an issue. So how do you approach that?
So, I try to just, again, I respect that if they don't feel like their weight is affecting them in any way, then I have to respect that. And at the same time, I have an obligation as, their medical provider to share with them in a sensitive way, what my concerns are and why. So it's not again, making it clear it's not a cosmetic issue. This is a health issue. And again, in a patient-centered way, would it be okay with you if I shared what are some of my concerns about your health? So that the way we talk about it, I think, is really important. And again, we honestly, I feel, have not as much to do as other influences in a family's life about what will lead them to be ready to change. So, I do think the pediatrician has an important role to play, and we can share our concerns with them. Sometimes, doing some lab can uncover some kind of hidden comorbidities that a family might not even be aware of. But more often than not, I feel like there are other events or other circumstances that really influence a family's readiness to change. I've seen it be another family member develops diabetes, or a family member has a heart attack, or perhaps the child is bullied at school and they're not really opening up about it to the family unless we ask a little bit more. So um, I don't know. I hope that answers your question, but I really try to, again, respect where they are in their readiness, and do what I can to share with them my concern, and at the same time leave an open door. If they're not ready to talk about it, okay, but I want them to know I'm there for them, so that if and when the time comes that they are concerned, that I'm ready to help. And part of that too, I think, is again, we benefit from that longitudinal nature of our relationship with families as pediatricians. So maybe not today, but maybe, let's check back in. Would it be okay if we check back in 3 months, maybe, and see how things are going? So just a few ideas.
I love that. And I love that you said, can I talk about concerns that I have about your health? So you said health, and I think that kind of opens that door a little better for them to be more, more accepting of you talking about it. And I was actually listening to, again, a podcast with Dr. Hessink this weekend, and it was actually testimonies of patients. It was really good. But they were talking about, all of them said that was one thing that really helped them with making changes, was that their providers always were there and willing to help. And they knew that they could come to them. And they were talking about how it was kind of like a revolving door. So whenever, like the one patient was saying that she wasn't ready, like her mom was ready, she wanted her to do it, and she wasn't ready. And she didn't end up doing anything for a couple of years. And then she came back and she said that she was ready at that point, and she really did make those changes. So I think, sometimes we want them to be ready, but they're not. And so, and I
Right.
think that's the hard part, is accepting that, what you said. I mean, we can't make them ready, but we can be there when they are ready, and we can make
Yes.
sure they know that we will be there if
Hmm.
and when they're ready. So
Yes.
I think that that's a really good point that you made. But all right, well, let's discuss about treatment options. Everybody, I think that's a big thing in the guidelines that there's been a lot of talk about and discussion, is the treatment options that are in the new CBG guidelines. So,
Sure. So again, we kind of talked about the overall approach being more of a motivational interviewing approach, but even underlying that is really the recommendation that treatment should occur within a medical home. Somebody that's going to be following the child, a practice that's going to be following the child long term, and using the principles of the chronic care model. Again, recognizing obesity often does follow children into their adult years. And so how can we apply that longer term approach and look at what surrounds the child in terms of how to support them and the family? Family centered, non stigmatizing are a couple of other things or phrases that really characterize the treatment of children with obesity, because as we all know from practice, most kids cannot do this alone. They need a supportive family to help make these changes and have these be family-based changes, and certainly non-stigmatizing. We want them to feel welcome in our office, not just physical things like chairs that are big enough and blood pressure cuffs that are big enough, but also our and our staff's attitude in approaching them and working with them, making sure that that they feel comfortable and non-stigmatized in the way that we approach their whole visit, and acknowledging again all those different drivers of the child's weight and health. And so we kind of think of the foundation of treatment as intensive health, behavior, and lifestyle treatment. So within the medical home, looking at how can we best, again, assess and address different health behaviors, and not just the what. It's more just as important, I think, is the how. So, most parents actually know, and a lot of kids know that maybe they shouldn't be drinking as many sugar sweetened beverages, and that eating out is often less healthy than eating at home, and some of those things. But the how to do it in the context of, nobody else in my family will drink just water, and we are out on the go a lot with different kid activities. So one of the nice features of intensive health, behavior, and lifestyle treatment is it helps build families build skill. Again, taking it beyond the what to do, but the how did we make these changes at home in a lasting way, so that this is something good for everybody, and these kids, we want them to maintain these behaviors into adulthood as they become parents and so forth. So that's the foundation, is intensive health, behavior, and lifestyle treatment. And it takes time, so that's why the studies we did utilize the review from 2017 that the U.S. Preventive Services Task Force did, as well as our own review, the Evidence Review Committee's review of the literature that had emerged since then. And 3 to 12 months is kind of the time period that was the most evidence-based, as well as at least 26 hours worth of contact to help build that foundation. And recognizing that above that, sometimes more intensive treatments are necessary. And so we did discuss, again, in addition to intensive health, behavior, and lifestyle treatment, that pharmacotherapy may be indicated for adolescents that are 12 and older with obesity, according to indications. And again, this is an area where the evidence was really emerging as we were writing the clinical practice guideline. And in fact, in 2022, I think there were 3 different medications that were FDA approved for youth with obesity. So in the use of those, making sure that pediatricians have the skills that they need to understand the indications, the risks, the benefits, and that it really is in addition to intensive health, behavior, and lifestyle treatment. So pharmacotherapy is an option, again, for adolescents in conjunction with intensive health, behavior, and lifestyle treatment. And then, we also did discuss the use of metabolic and bariatric surgery, because that evidence is accruing, it's building, and it has been for several, a number of years now. And so looking at referring for a comprehensive evaluation for surgery for kids that are 13 and older with severe obesity. That was one of the recommendations. And I think it's important to emphasize a couple of different things with that recommendation. One, that it's offering referral. It's not offering surgery. It's offering referral, and it's offering referral to a comprehensive center that is multidisciplinary, that is accustomed to working with children, with adolescents, to help them, to do that thorough evaluation for their surgery readiness, psychologically, physically, and making sure that they are equipped for life after surgery. So there's, at least a 6-month period, oftentimes longer, that youth spend in these comprehensive pediatric metabolic and bariatric surgery centers, making sure that they are thoroughly evaluated and then have the learning and the skills that they need for the surgery itself and life after surgery. So that is the most intensive treatment recommendation made. And, the criteria really came directly from the 2019 AAP policy statement on metabolic and bariatric surgery. So that's looking at kids with class 2 or higher, class 2 or 3 obesity, class 2 with complications such as type 2 diabetes or obstructive sleep apnea, or a number of different complications. And then class 3, kids with class 3 severe obesity are not required to have a comorbidity, although a comorbidity is often present. So that's kind of the spectrum of treatment options that we talk about. And we kind of think of it like a house, with the foundation being intensive health, behavior, and lifestyle treatment, again, within the medical home and within the chronic care model and the whole child approach. And then above that, you may need to add stories, so to speak, of the house, depending on, a number of different factors. So.
Yeah, I like that idea about the stories, or that example, illustration. That's a good illustration. So are insurance companies paying for bariatric surgery for children that are 13 and above, or does it depend on the insurance company?
It depends on the insurance company.
Okay.
Some are and some are not. And so that's where advocacy really is going to, I think, play more and more of a role, and pediatricians building our skills in advocacy, because these are effective treatments, and we want all kids to have access to the effective treatments that are indicated for them.
So I have a question. Did the guidelines address medications for children under 12, or is it only 12 and above?
So the actual key action statement was for kids 12 and older. However, there are more studies being done now looking at kids even as young as 8. And certainly, there are kids with certain genetic conditions that are younger than 12, for which medication is indicated and approved. So there was a consensus recommendation for kids 8 to 11. Where obesity pharmacotherapy may be indicated.
Okay.
Again, as an adjunct to the intensive health, behavior, and lifestyle treatment.
Yeah. Okay. Right. Well, anything else about treatment?
I think that, those were the main treatment tools that
Okay.
we discussed. And there are a number of different resources that are available and that will be becoming available in the coming next few years to help support pediatricians to become more familiar. I think one of the more common questions that we get is, well, what if an intensive health behavior and lifestyle treatment program is not available in my community? What do I do then? And that's a very fair and valid question. And
Yes, it is.
we spend some time um, in the guideline talking about, if you don't have a program, here's what you can do. What are things you can do? What are partnerships that you can look for to help kind of build your own, so to speak, and partner with other organizations that can help provide parts of intensive health behavior and lifestyle treatment.
Good. So can you tell me about some of those resources? Where can pediatricians find resources?
Sure. Yeah, so probably the best one-stop shop for the resources would be the AAP website. So if people just put in www.aap.org and they put a / obesity CPG, type that in, and then that's going to lead them to all the resources that are available currently. And those include an algorithm to help guide physicians, pediatricians, other pediatric healthcare professionals. And you'll notice we use the term pediatricians and pediatric healthcare providers because we want to be as inclusive as possible in our discussion. But there's a nice algorithm, as well as a number of different tools that are on that website. There's graphics, there's CME modules, there are nice short videos that tell about just little different aspects of the CPG, like their little 2 or 3 minute discussions by some of the CPG writing committee members. There's a clinical flow assessment and for assessment and evaluation, and then there's a separate one for treatment that are a little bit more detailed than the algorithm, which is just like a front and back. But the evaluation flow diagram goes into a little bit more detail, and then the treatment one does as well. And there's some coding guidance as well for mapping billing codes to the CPG, and some quality improvement modules that pediatricians can use as they're recertifying for their American Board of Pediatrics qualifications. That this may be able to be used. And then some different patient and family resources as well. There are at least 5 different new articles that have been put up on the healthychildren.org website. And then again, I mentioned the self-paced CME modules, the explainer videos, the podcast that you've already
Yes.
found.
Yes.
So yeah, a lot of different resources are there, and it'll take time for people to, go through, but please, we want them to use them because, our biggest hope is that this guideline is useful, and that it is actionable by the clinicians that are going to be using it.
Yes, definitely. Now, the algorithm, is that a new algorithm that's different from the one that was in the 5210 clinical practice
Yes.
chart? Okay.
Mm-hmm.
Great.
Yeah.
Okay. Perfect. Well, yeah, that sounds great. And yeah, we're going to put all of this information in the chat for you guys. But yes, you'll have it because, yeah, and those podcasts, they really are good. I would highly recommend them. I actually listened to, I think, 5 this weekend, but they were wonderful about how to approach patients. And so, yeah, I think this will be useful.
We sure hope so. And we'd love, feedback. So feel free to reach out. There's contact information on the Institute for Healthy Childhood Weight website about the tools, and definitely feedback is appreciated.
Great. So are there any other things other than managing patients that you feel like pediatricians should do with childhood obesity? Does advocacy have a role with pediatricians?
Yeah, I'm really glad you mentioned that, Miranda, because as you know, especially for the treatment tools that we now have available, more advocacy is going to need to be present to help get kids access, because not many insurers will cover a more intensive health, behavior, and lifestyle treatment. There are a few out there that are, and they can be used as examples to other insurers, to, on how to develop a benefit such as this, but advocacy on a number of different levels. So pediatricians, absolutely, we're the ones that are seeing the patients, and I think from my work with insurers, what one of the things that they've told me is we really like hearing the patient stories. We want to see how is this actually affecting the child that you're taught, or the children that you're seeing and are wanting more coverage for, or different coverage. So we have a role to play, definitely. AAP has some resources. They have like an advocacy training workshop that they do, and a number of different just online resources that pediatricians can avail themselves of. And then the state chapters, the state AAP chapters often are great places to meet with like-minded pediatricians who want to expand coverage, and maybe their interest is expanding coverage for a different health condition than obesity, but that's okay, because some of the skills are common to all the different conditions. So the state chapters, and sometimes the state chapters have payment councils, or they may belong to or have the ability to advocate with insurers along with other child-focused organizations or health-focused organizations. So I think, there are the state chapters that are resources. And then, on the national level, the AAP is advocating and will continue to advocate for improved coverage for these treatments. So advocacy, also advocacy doesn't have to be for insurance, better insurance coverage. There's lots of other ways that pediatricians can advocate. They can even advocate with their local medical schools or osteopathic schools to include more training on obesity, nutrition, physical activity in the the training. There are a number of different things that can be a number of different activities that can still be considered advocacy. Maybe it's that you really like the EMR and you really want to try to include better tools to help manage patients with obesity within the electronic medical records. So AAP also has some resources for that are being aligned to the CPG, so that healthcare systems that want to incorporate those in their EMR can do so. So there's a lot of room for advocacy beyond kind of traditional policy.
That's great. Well, this has been wonderful. Thank you so much for joining us. Is there anything else that you feel like pediatricians need to know, or about the CPG?
Well, I appreciate you asking me to be a part of this, and I think the way that you guys have your Echo designed, which is a podcast, I think is great, and it's a model for other state AAP chapters and other groups that want to get information out to clinicians. So appreciate everybody's attention, and again, your dedication to getting the best tools in the hands of the pediatric clinicians and supporting them. Is great to have learned about you and your organization, Miranda.
Great. Thank you so much, Dr. Hampl. Thank you for being here.
Sure.